Hello and welcome everyone to tonight's webinar, beautifully titled Beyond the Leaks, Strategies for Treating Urinary Incontinence in Women, brought to you by Capital Health Network and gynecologist Dr Omar Adham. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. And I pay my respects to their elders, past and present. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending today's event. Tonight's webinar focuses on female incontinence. I'm Dr. Leonie Harcourt, a GP education advisor at Capital Health Network. Also with me tonight is the events lead at Capital Health Network, Kunal Mohiti, and of course, gynecologist Dr. Omar Adham. Omar is a skilled and accomplished gynecologist. He is currently working as a senior gynecologist at the Canberra Hospital and is known for his expertise in complex urogynecology cases, as well as laparoscopic surgery and surgically complex endometriosis. He has made significant contributions through clinical research and teaching, and he also operates a private medical practice providing comprehensive gynecological care to a diverse patient population. So just the usual housekeeping before we start. All participants have been muted, and we'll have a question and answer session at the end of the presentation. And please type all your questions and comments into the Q&A section and not the chat box on your Zoom window. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. CPD, so it's getting to the pointy end of the year for CPD, so I'm sure everyone's keen to hear that you can self-report 1.5 hours of educational activities to your CPD home. CHN will email you a certificate of attendance after the event, and please fill in the post-event evaluation survey. And also, before we start, just a reminder on Health Pathways, which has guidelines and advice on the treatment of many conditions, including incontinence. And the login is together, or lowercase, the word together. And the password is for health, FORHEALTH, and that's all lowercase too. So that's enough from me. And now over to the interesting bits with Dr. Adham. Thank you.
Good evening, everyone, and thanks for joining us tonight. I picked this topic because it's a very common clinical scenario in our community, and I'm pretty confident that most of you are familiar with the information I will provide and we will discuss tonight, but I thought it's always good to have a refresher periodically. The presentation labeled Beyond the Leaks, Strategies for Treating Urinary Incontinence in Women. I'll start with defining the condition, where urinary incontinence is the involuntary loss of urine, and it affects anywhere between 10 to 40% of the Australian community, with urinary stress incontinence accounting for approximately 50% of those cases. Mixed incontinence, 1/3 of the females who have incontinence experience mixed incontinence, and the prevalence rises with age, and especially or particularly for urge and mixed incontinence types. It has a significant impact on the quality of life, particularly in the aging populations, emphasizing the need for effective treatment strategies. So I will start by defining what's considered a normal bladder function. We'll start with the frequency, where we would expect passing urine 4 to 6 times per day and once or twice per night as normal. The volume is generally around 250 to 500 mils, 1 to 2 cups of urine each void. The stream is expected to be steady until the bladder is empty, and the patient should be able to delay passing urine until it is convenient. No leakage of urine between visits to the toilet should occur. First, I wanted to talk about the continence mechanisms in women, and then we'll move on to the pathophysiology of the urinary incontinence. So continence is quite a complex process, and it relies primarily on a coordinated effort between the bladder, the urethra, the pelvic floor muscles, and the connective tissue. And the function of the lower urinary tract involves two phases. The first phase is the storage phase, and the second phase is the voiding phase. For proper storage, the bladder must expand while maintaining low pressure and avoiding involuntary contractions during the filling phase. The bladder innervation plays a key role in maintaining continence. The body of the bladder has a parasympathetic nerve supply, and this manages the bladder relaxation and contraction. And the bladder neck is innervated, has a sympathetic innervation, and this regulates the outlet closure. And for the normal urine storage is dependent on a closed outlet and a relaxed bladder, and that will maintain continence. The outlet closure is managed by the bladder neck and the urethral smooth muscle and the rhabdosphincter sphincter muscle that is under voluntary control. In response to pressure, and particularly intra-abdominal pressure, the rhabdosphincter sphincter and the pelvic floor also respond to the rise. The urethral mucosa, an intact urethral mucosa is essential for a watertight seal. And the pressure balance, continence is maintained when the urethral pressure exceeds the intravesical pressure. And then we will talk about the voiding phase. The voiding phase is governed by the micturition reflex, which is under voluntary control. The voiding phase initiation begins with relaxation of the outlet and a sustained detrusor contraction. The micturition reflux normally is under voluntary control and is coordinated by the pontine micturition center and spinal cord relays within the spinal cord for proper coordination. The types of urinary incontinence are stress-induced incontinence, urinary urge incontinence, mixed urinary incontinence, overflow urinary incontinence, fistula-related incontinence, and functional incontinence. In this talk, I'm going to focus on the most common two types, which is the stress-induced urinary incontinence and the urge. And a short definition for the first stress urinary incontinence is weakness in the urinary sphincter and or pelvic floor. For urge incontinence, there's detrusor overactivity at low volume with little warning. And then there's the mixed incontinence that involves stress and urge. Overflow urinary incontinence is an overflow from chronic retention. And that is due to either outlet obstruction or poor bladder muscle function. Fistula-related incontinence is related to connections between the vagina and bladder, vagina and ureter, or vagina and urethra. Functional incontinence is the inability to toilet properly due to physical, such as mobility, or mental, such as dementia limitations. I'll talk now about the pathophysiology of urinary incontinence. Dysfunction overflow. Urinary incontinence occurs when there is dysfunction in either the storage or emptying function of the lower urinary tract, and coexisting dysfunctions where the urethral sphincter dysfunction and the bladder dysfunction can actually coexist at times, or most of the times they do. The continence mechanism is resilient and often compensates for individual dysfunctions within the lower urinary tract. So compensation mechanisms, various components of the continence mechanism may compensate for each other. An example is the impact of aging. So women who may remain asymptomatic after childbirth injuries of potentially, say, pelvic floor, until aging leads to a loss of the urethral sphincter function. For urinary stress incontinence, we talk about mechanism, and this occurs when the vesical pressure exceeds the urethral pressure due to a sudden increase in the intra-abdominal pressure. So cough or heavy exercise, straining, the urethra is unable to maintain a higher pressure than the bladder. And the causes is generally weakness of the pelvic floor or urethral sphincter muscle deficiency. It is further complicated by conditions such as bladder neck hypermobility, which leads to loss of the bladder neck support, and also intrinsic sphincter deficiency, with most patients having elements of both conditions in varying degrees. The pathophysiology for urinary urge incontinence is primarily caused by detrusor overactivity or low bladder compliance, which reduces capacity. The detrusor overactivity is characterized by involuntary detrusor contractions during the bladder filling phase. And there are two types of detrusor overactivity: a neurogenic bladder, where it originates from neurological causes, and idiopathic myogenic, where there's no identifiable cause. So it originates from changes in bladder epithelium or the detrusor muscle. That's the urgency trigger. Two theories. One is called the myogenic theory, as I mentioned earlier on, and this suggests that age-related changes in the smooth muscle leads to hyperexcitability of the bladder. The neurogenic theory, where the detrusor overactivity is due to denervation at the spinal or the cortical level, so the spinal relays or the pontine center, leading to hyperactive voiding and neurological conditions such as Parkinson's disease and strokes. And now I want to talk about the clinical assessment for urinary incontinence. We will focus on the most common again, whether it's stress incontinence, urge, or both. It's important to distinguish the different types, as this guides in management, and the diagnosis is often determined by careful history and a basic clinical assessment. History can be divided into four key components: defining the type of incontinence, and then the causes and precipitants, excluding other pathology, and assessing the severity and the impact on patient's life. So I'll talk about the first component, defining the types of incontinence. We generally ask about triggers for stress incontinence, such as physical exercise, coughing, sneezing, and lifting, and triggers to urge incontinence, such as hearing running water, hand washing, arriving home, a sudden severe need to void, and urgency without the loss of urine, and the overactive bladder, the dry type, and also constant versus intermittent leakage, and to clarify the amount of urine loss. Trying to identify causes and precipitants. A general urinary tract history is crucial, and that includes an assessment of the urinary frequency, day versus night, asking about dysuria, hematuria, bladder irritants such as caffeine and alcohol, assessing risk factors for stress urinary incontinence, parity, large babies, instrumental deliveries, breech deliveries, and also inquiring about chronic lung conditions that lead to chronic cough and obesity. Also, we try and identify reversible causes such as diuretics or medications, diuretics, lithium, alpha blockers, and there's a few others that I haven't mentioned. We look at diabetics and the level of control and assess for constipation. Inquire about previous surgery for urinary tract and gynecological surgeries like prior prolapse repairs, prior urethral slings and other incontinence procedures, and also establish whether or not a hysterectomy has been performed. And then touch base on excluding other pathologies. So patients with stress and urge urinary incontinence shouldn't have hematuria, macroscopic or persistent. Microscopic requires further investigations from renal imaging, cystoscopy, to exclude or diagnose other pathologies such as bladder cancer and calculi. They shouldn't really report pain. Suprapubic or dysuria suggests pelvic or other urinary tract pathology, and it's gradual. A gradual onset is typical, so a recent or an acute onset should also raise some alarm bells, as it may indicate other pathology. Other red flags include obstructive void symptoms, such as straining to void, sensation of incomplete bladder emptying, recurrent UTIs, neurological symptoms, new onset paresthesia, weakness, back pain, visual disturbances, altered bowel habits, may suggest a neuropathic bladder. So atypical features or severe symptoms do warrant a referral to a specialist for further assessment. And then assessing the impact of incontinence, as this can be done through both subjective and objective measures. So bothersomeness, gauge the impact on the patient's lifestyle by asking about activity restrictions and also the use of incontinence pads. Ask about reducing or stopping activities like social engagements and sports, degrees of disruption to daily activities, and the emotional impact that it has on them. And also identify patient goals. So determine the patient's treatment goals and preferences. Physical examination involves abdominal, pelvic examination, rectal examination, and neurological examination. So in abdominal examination, I generally look for a palpable bladder after voiding, which may suggest chronic urinary retention. The pelvic examination, we assess for vaginal mucosal atrophic changes. We also recommend stress tests or coughing or straining, Valsalva maneuver to demonstrate leakage, provided that the bladder is to an extent full. Also assess for prolapse, identifying the location, anterior cystocele, posterior rectocele, vault or uterine prolapse, and the severity of the prolapse is important because the more advanced the prolapse, the more it interferes with the bowel function and the voiding pattern. We also assess the pelvic floor muscle tone, graded out of 5 as per the Oxford system, 0 no tone and 5 excellent tone. assess the ability to contract and endurance, sustain pelvic floor contractions, and also undertake a bimanual examination to exclude other pathologies such as pelvic masses that might put pressure on the bladder and simulate urge incontinence. A rectal examination is to assess for constipation, also the anal tone, which would have a negative impact on voiding, and a neurological screen assessing perineal sensation, anal tone, and a lower limb neurological examination for lower motor neuron problems. Consider generally screening for multiple sclerosis and Parkinson for those who are at risk. And a critical, crucial tool in managing the voiding dysfunction and incontinence is the bladder diary. There are many excellent bladder diaries, and I would certainly recommend the IUGA bladder diary, which is the International Urogyne Association. More than happy to email it with a few other documents to those that are interested. If you could just, I'm happy to provide my email and email me a request, and I could do that for you. But it's critical, it's crucial. So the benefits is there's an objective measure of symptoms, so it provides a quantifiable record of the patient's voiding habits, making symptoms tracking over time reliable. Also symptom comparison and treatment tracking, as it allows clinicians to compare symptoms over time, especially with treatments, and this also enhances monitoring. Patient engagement and awareness. Patients become actively involved in their treatment and gain insight into their habits, assisting in bladder retraining programs. Diagnosing polyuria, the bladder diary is also essential for diagnosing polyuria, which is defined as 24-hour urine output that's greater than 40 mils per kg, which has a completely different management, obviously, to urge incontinence. It also helps, and with regards to the fluid intake and the patient compliance, within the bladder diary, while fluid intake can be deduced from the 24-hour urine output, omitting this simplifies the chart and actually improves compliance. So too much information puts them off. And then how do we interpret the bladder diary? So it reveals several potential patterns that can point to specific diagnoses and most of the common conditions. So if you get frequent small volume voids, this is generally seen in an overactive bladder syndrome, and also in painful bladder conditions such as interstitial cystitis. If you get frequent large volume voids, then that's commonly caused by polyuria, and that's often due to excessive drinking or conditions like poorly controlled diabetes mellitus. If you have a pattern of small volume voids with low urine output, it generally is deliberate fluid restriction to control other urinary symptoms. And nocturnal polyuria may be linked to aging, sleep apnea, other medical conditions such as cardiac failure, and most commonly excessive fluid intake at the evenings. The next 2 or 3 slides will be about the initial basic investigations for urinary incontinence in general. So urine analysis and cytology is recommended to exclude urinary tract infections and hematuria. Post-void residual volume, so measured using catheterization or an ultrasound, and that mainly is to rule out overflow incontinence. So limitations of clinical assessment, which includes history examination, bladder diary, post-void residual, and urinalysis. Despite these thorough assessments, there remain challenges in the diagnosis due to mixed symptoms, severe incontinence, vague patient histories can make clinical diagnosis difficult. Also, there's generally or periodically symptom overlap. So similar symptoms such as urine loss with activity that may suggest urinary stress incontinence, but it also can occur in urgent incontinence due to detrusor overactivity, which complicates the diagnosis. Unreliable bladder symptoms. So the bladder is often called an unreliable witness due to complex and variable nature of the symptoms. And when there's doubt, urodynamic studies in complex cases is indicated for all incontinence patients. Not all incontinence patients, so only complex cases and when there's uncertainty about the diagnosis. So we'll talk about urodynamic studies. So they are the gold standard for bladder function. So they provide most detailed information on bladder function. It's really similar to how an echocardiogram can assess heart function to an extent. They vary from a simple cystometry to complex cystometry. Also patient complexity determines the study type. So more complex urodynamic studies are required with intricate bladder dysfunctions using specialized equipment. So the next thing would be to mention the indications. When there's uncertainty or unclear incontinence diagnosis, they do help clarify where the patient history doesn't provide a clear diagnosis. If we're considering invasive or surgical treatments, urodynamics can confirm the type and must confirm the type and the voiding function to guide us in the surgical treatment options. If the conservative management had failed, that's another indication. And in complex cases where patients again present with mixed symptoms, failed surgery, or if they have a history of neurological disorders, more clarity will be provided with urodynamics. The information gained from urodynamic studies includes bladder overactivity. So the study will demonstrate detrusor overactivity, indicating an unstable bladder contraction. So that generally occurs during the filling phase or filling phase part of the study. It also demonstrates the bladder compliance, so the elasticity of the bladder, which is important for it to maintain low pressure in the filling phase. Obstruction and flow studies by measuring different physical urethral pressures during different phases, it'll help identify obstructions in the urinary tract and the contraction of the detrusor contractions, the quality. So with regards to clinical assessment, conclusion is that clinical assessment is the foundation. Assessment relies on the history, physical examination, the bladder diary, a basic urine and bladder testing. The diagnosis of incontinence, stress, urge, or mixed urinary incontinence can often be diagnosed clinically, which leads to conservative management, and specialist referral is recommended in atypical cases or failure of conservative treatments. So I'll first talk about the overactive bladder syndrome, about the management and the treatment options, and then we'll follow with the urinary stress incontinence. So with regards to the first, overactive bladder syndrome is defined by urgency, frequency, and nocturia, sometimes with urinary incontinence. It is often managed in the primary care setting. The objective of the information for the next slides is to review the overactive bladder syndrome and provide general management advice to our GP colleagues, recognizing or highlighting the impact on the community, as this condition affects up to 17% of the population, and it increases with age, and it significantly impacts the quality of life. Defining overactive bladder syndrome is considered a symptom complex. It is characterized by urgency, frequency, nocturia, with or without urinary incontinence. Exclusion of underlying factors, as the syndrome is not due to metabolic causes like diabetes or other local issues such as infections or stones. And the key symptom to it is urgency, which is the defining symptom for an overactive bladder. The clinical significance, there's high prevalence, as in Australia, 42% of adults report urinary incontinence, 16% experience urge incontinence. It has got a substantial impact on the quality of life. Patients have reduced work productivity, sexual dissatisfaction, and higher rates of depression, as well as poorer mental health. In postmenopausal women with urge incontinence, this particular group is at a higher risk of falls, fractures, and poor sleep quality. The risk factors include vaginal birth, delivery, instrumental delivery, older age, obesity, chronic constipation, and childhood urinary symptoms. These are linked to adult urgency, frequency, and nocturia. Diagnosis of overactive bladder syndrome. So the initial investigations, and before we delve into that, we must remind ourselves that it is a diagnosis of exclusion. It is diagnosed by excluding other causes. Initial investigations are key to rule out other conditions. So these initial investigations will include urinalysis to exclude infection, to look at hematuria and glycosuria, a urinary tract ultrasound to undertake a post-void residual measurement, and a frequency volume chart, which will track the frequency and the volume for at least 3 days to rule out polyuria, bladder diary for a minimum of 3 days, and this will significantly have a significant role in assessing the voiding pattern. Again, just back to initial investigations, touching a bit more detail on the urine cytology. So that's performed in 3 voided specimens over 3 days. It's effective for detecting high-grade lesions and carcinoma in situ of the bladder, but not as reliable for low-grade lesions. The post-void residuals, an increase in the post-void residual may lead to urinary frequency and nocturia, and also anticholinergics may worsen bladder function and lead to urinary retention, and demonstrated by high post-void residuals. The secondary investigations, if the primary assessment doesn't provide sufficient clarity, I know I've mentioned urine cytology in the previous slide, but culture and sensitivity in a midstream urine is considered first and cytology's secondary investigation. Also urodynamic testing, cystoscopy, and further upper renal tract or spine imaging may be necessary. Treatment for overactive bladder syndrome. I'm going to talk about behavioral modification. The goal is to reduce incontinence by changing the patient's behavior and teaching them, excuse me, continence skills. I'd like to also highlight that spontaneous resolution can occur, so up to 30% of women with urge-only incontinence may experience spontaneous resolution within 2 years. And if patients opt for no treatment, that's certainly an option. Given that the overactive bladder syndrome is a symptom complex, so choosing to do so is acceptable. So the first line treatment, initial management involves lifestyle interventions, bladder training, pelvic floor exercises, and anti-muscarinic or anticholinergic agents, and we'll talk about these in more details. The second line treatment has more invasive options, including bladder Botox injections, neuromodulation, or surgical interventions like cystoplasty. Excuse me. A referral to urogynecology or urology if conservative management fails. A patient should be referred to a specialist, urogynecology interest, or urology for further evaluation. So the first line therapy for an overactive bladder syndrome, primary care initiation. So it can be started in the primary care setting. Lifestyle interventions and bladder training, a combination of these and behavioral modifications are the key component. So anticholinergic medications may be added to control symptoms if the initial intervention fails, or if it doesn't produce the desired results, or if both are used in combination, the outcomes are actually more better. You talk about lifestyle interventions, so that includes fluid intake adjustment, so decreasing fluid intake to reduce incontinence and frequency, or increasing it to improve urine concentration when patients are quite dehydration, as they're significantly limiting their fluid intake to deal with incontinence, various types of that. Smoking cessation helps significantly. Dietary modifications, so reduce triggers such as caffeine and alcohol and carbonated beverages. Weight reduction, reducing central obesity, as this can alleviate pressure on the bladder and will help with urge incontinence, and bowel regulation is very important. Constipation leads to straining, and that can compromise the continence. Behavioral treatments, so some facts about those. Effectiveness in older adults. The behavioral treatments can reduce leakage by 50 up to 80%. Patient motivation, so 20 to 30% of patients become dry, but success depends on patient's motivation and consistent follow-up. Bladder training versus medication. Bladder training reduces frequency and incontinence more effectively than anticholinergics alone. Cognitive impairment. For women with cognitive impairment, prompted and timed voiding programs are recommended and as a part of the behavioral treatment intervention. So behavioral training, the goal is to teach them to inhibit or interrupt detrusor contractions for better control. Pelvic floor muscle training. Training with or without biofeedback helps increase urethral pressure and inhibit contractions and control leakage. Exercise prescription. So older adults should start with 2-second contractions and gradually increase to 10-second repetitions for maintenance. Freeze and squeeze technique. When urgency occurs, tighten the pelvic floor muscle until the urgency passes before heading to the bathroom. Maintenance and supervision. A 3-month supervised program is essential to see benefits with guidance from continence-trained professionals. I mean, these are the initial recommendations I make on the initial consultation, and then generally, if they're willing to see a women's health physiotherapist, I'll refer them on to them. Some patients can't afford to do that. So, you know, at primary care level or us, we're expected to at least provide this basic advice. There's also a community women's health physiotherapy service that we hold at the Canberra Hospital. And again, I'm happy to provide a referral form and information, contact information, if there's interest for that. Bladder training. Again, goal is to modify the function, reduce the voiding frequency, increase the bladder capacity, and eliminate detrusor overactivity. So we're talking about exercises for urge incontinence. The methods start with the longest comfortable voiding interval and use scheduled voiding rather than responding to the urgency prompts. Urge suppression techniques, distraction, relaxation, or self-affirmation techniques. These can help patients reach the scheduled void time. Gradual increase. So after 1 to 2 weeks, we can increase the intervals by 15 minutes, working towards longer intervals. And the minimum training duration should be at least 6 weeks to see benefits. It's also worth mentioning that topical estrogen in post-menopausal women is a treatment for atrophic vaginitis. So local vaginal inserted estrogen cream or pessaries can treat the dry vagina and the urethral tissues in post-menopausal women. Sometimes they present with constant dribble, and that's generally for due to deficiency in the estrogen that leads to urethral that will disrupt the urethral mucosal integrity. And you will find by just prescribing this that improves quite significantly. So I've talked about this already, but the relief for the overactive bladder symptoms. The options are Ovestin cream and Vagifem low pessaries, and these are prescribed twice weekly, generally for a 6-week period, and then they can go on maintenance once weekly. This also has a significant role in preventing recurrent urinary tract infections. The next thing we'll talk about the medical non-invasive pharmacological therapy or overactive bladder syndrome. So empirical anticholinergic or antimuscarinic treatment. Patients with overactive bladder can be treated empirically with these agents in primary care setting, avoiding invasive procedures such as urodynamic testing and so on. And this is when the diagnosis is clear. The mechanism of action for the anti-muscarinic agents, they inhibit the cholinergic receptors in the detrusor muscle during the filling phase, reducing the sensory input and muscle contractions. Impact on micturition. These drugs compete with the acetylcholine, and during micturition, massive release of acetylcholine can reduce their effectiveness. The anticholinergic medication. So the controlled release compounds are generally better tolerated than the immediate release formulations. They have similar efficacy, and most side effects result from inhibition of the muscarinic receptors outside the bladder. Switching agents, if symptoms control is inadequate or side effects are intolerable, try another anti-muscarinic agent before considering other therapies. Managing side effects, common side effects such as dry mouth and constipation are best to be managed prior to discontinuing the medication. Again, we want to talk about their effects in the elderly. Cognitive dysfunction, including memory loss and attention deficits, are particular side effects in the older adults. The transdermal formulations, such as the oxytril or the oxybutynin in transdermal gel form, appears to avoid cognitive side effects. The risk of crossing blood-brain barriers, where the oxybutynin may be more likely to do so, increasing the risk of cognitive side effects, where the newer agents like darifenacin, solifenacin, and tolterodin, they have a significantly lower impact on cognition. The medications, the anticholinergic medications available are ditropan. This is non-uroselective, so has a higher side effect profile, and the general dosage is 2.5 to 5 milligrams, 2 to 4 times per day. It's inexpensive, but the side effects like dry mouth and constipation are generally more pronounced, and also the confusion and sedation or the cognitive impairment in the elderly is higher than others. The oxytril, which is the patch form of the oxybutynin, is again non-uroselective. It's generally prescribed one patch twice weekly, has a lower side effect profile than the oral form. Unfortunately, I don't think it's wasn't PBS subsidized, and I don't think it is currently. Ditrol is the next three are uroselective, meaning they have fewer side effects, but all of those are not listed on the PBS. So the ditrosol is 2 to 4 milligrams once daily. So it has a similar efficacy to oxybutynin. Enablex is also uroselective, as I mentioned, and the dose ranges from 7.5 to 15 milligrams once daily. Similar efficacy to oxybutynin with an improved side effect profile. And Vesicare, again, similar properties to Enablex and ditrosol. The efficacy of anticholinergics, all of those have similar efficacy in reducing urgency, frequency, and episodes of urgent incontinence. The newer preparations like darifenacin, solifenacin, and transdermal oxybutynin, ditrosol, have fewer side effects due to extended release, as we mentioned before. The common side effects include dry mouth, constipation, dry eyes, blurred vision, indigestion, and heartburn. switching medications or adjusting doses. If symptoms are not controlled or side effects are intolerable, try another anticholinergic or adjust the dose. The trial periods, generally 4 to 6 weeks, needed to demonstrate benefit and effectiveness of the medication. And combining anticholinergics with behavioral therapies like bladder retraining or pelvic floor rehabilitation can enhance effectiveness. And the second group is the selective beta-3 adrenergic agonist. The only one we have in Australia is Betamiga, mirabegron. It's the first of this group, and it was introduced in Australia in 2014. This relaxes the bladder smooth muscle to improve urine storage. So it increases the bladder capacity. It's very well tolerated. It avoids the common anticholinergic side effects. Just consider blood hypertension with this medication, as it's not suitable for patients with severe uncontrolled high blood pressure, but safe for those who have well-controlled hypertension. And then we'll talk about the second line of therapy for the overactive bladder syndrome. This involves intravesical botulism or Botox injections. This prevents the way it works is that it prevents the acetylcholine release at the neuromuscular junction, which results in temporary chemo denervation and muscle relaxation. So paralyzes the detrusor, and it's effective, in my experience, depending, anywhere between 6 to 12 months. The technique involves multiple injections placed under cystoscopic guidance directly into the detrusor muscle, and avoiding the trigon. And this can be done as an outpatient setting or under a general anesthetic, based on patient preference. Efficacy, complete continence achieved in 40 up to 80% of patients. There's a bladder capacity improvement at about 55 to 60% average, with the maximum benefits occurring between 2 to 6 weeks and maintained for 6 to 12 months. Repeatability, injections can be repeated as necessary to maintain the bladder function, and it's generally gauged based on the first treatment. You see, how satisfied the patients are for what period of time. And then as the urgency starts to be bothersome to a significant extent, again, that's when you will repeat the injection. Posterior tibial nerve stimulation, PTNS, this is a form of neuromodulation. It's a minimally invasive or a non-invasive form of neuromodulation treatment. The mechanism is the device sends electrical impulses through the tibial nerve in the foot to the sacral nerve plexus, regulating the bladder function. A very tiny needle is inserted behind the ankle and it's connected to the device that sends electrical signals to bladder control nerves. So that's, again, in the spinal cord relays. The effectiveness studies show patient response rates up to 80%, with improvements in frequency, urgency, and quality of life. The treatment protocol, the initial treatment involves 12 weekly sessions. Each lasts around 30 minutes. No special preparation is required. And maintenance therapy after the initial phase, where the frequency depends on individual response, again, similar to really the bladder Botox therapy. The advantages and the disadvantages of this procedure. Well, it's minimally invasive with no medication-related side effects. However, the costs are not covered by Medicare or health funds. We'll briefly touch base on third-line therapy. A specific type of neuromodulation is utilized here. So the objective is in this type of treatment is altering nerve signals to the bladder through electrical stimulation. We've discussed the PTNS already, and that, again, I would say is a second-line therapy. The third line really is sacral neuromodulation. A device that's currently used in Australia is the EnterStim. This delivers electrical impulses to the sacral nerves to modulate bladder control by sacral nerve stimulation. It's an implantable electrode in the S3 foramen, which stimulates the pudendal nerve. So a trial is done prior, where a temporary wire is placed for 5 to 7 days, with avoiding diary tracking for clinical assessment. If there's more than a 50% improvement, then a permanent S3 lead is implanted and has a potential benefit for up to 5 years. I mean, that's quite an invasive procedure, I must say. And it's generally done by a urogynecologist in a tertiary level center or a urologist. So key points to remember: the diagnosis of the overactive bladder syndrome includes frequency, urgency, nocturia with or without incontinence. It significantly affects the quality of life, potentially leading to depression and strained relationships. Exclusion of pathology is important. Initial treatment involves lifestyle changes, pelvic floor rehabilitation, bladder retraining, anticholinergics, and are considered the first-line treatment. And caution in elderly, so care is needed when prescribing anticholinergics due to the potential side effects and particularly cognitive impairment. Then we'll talk about urinary stress incontinence, mainly surgical management, and that'll probably be the end of our talk. The lifestyle changes and pelvic floor rehabilitation are similar to the urgent continence approach. Lifestyle modifications, pelvic floor exercises are recommended. There is specific continence pessary that are used to support the bladder neck and improve incontinence to a certain extent, particularly in cases where there is a hypermobile urethra that leads to urinary stress incontinence, or if there is a large anterior compartment defect, particularly cystocele, that causes urinary frequency and dry urinary urgency. Continence pessaries are particularly helpful. The factors influencing the management are divided into patient factors and surgeon factors. And again, aside from lifestyle adjustments, mainstream therapy is surgical interventions for urinary stress incontinence. So the types of urinary stress incontinence, in specific, the severity, the bladder function, neurological conditions, coexisting neurological conditions, tissue quality that will affect the type of surgery recommended, comorbidities, prior surgery, and the patient preference. And from surgeon factors, it's the experience of the surgeon with those particular procedures, the personal preferences based on experience and specific surgical skills. So procedures for urinary stress incontinence include Birch-Kolpo suspension. This is a surgical elevation of the bladder neck using a suprapubic approach. It's a very old operation. It has good track record. Previously, it's all done by open laparotomy, which was quite a morbid procedure. And now most of us do it, or those who do it laparoscopically, which is a minimally invasive procedure. Pubovaginal slings. So these are native tissue slings placed under the bladder neck to provide support. Well, options include autologous slings, allografts, and xenograft slings. Synthetic mid-urethral slings. These are polypropylene mesh slings. They're placed retropubically or via the transobturator foramen to sit under the bladder neck, and they're minimally invasive. There's also bioinjectables, urethral bulking agents. These are injected under cystoscopic guidance into the urethra to bulk the tissue and improve mucosal coaptation, enhancing continence. There is female artificial urinary sphincters, and also adjustable continence therapy, which is minimally invasive device with adjustable balloons placed again at the level of the bladder neck. Risks of surgery. So there's a balancing act between undercorrecting and overcorrecting the incontinence or the stress incontinence. So undercorrections may result in persistent stress urinary incontinence, so failure of the surgical intervention, while overcorrection can lead to obstruction, retention, or bladder overactivity. So generally and this mainly refers to Birch-Goldberg suspension and mid-urethral slings. The mid-urethral slings, TVT is generally what the primary first choice. We actually place those tapes tension-free because in the healing process, the fibrous tissue will put more tension on the tape. So, and that's generally enough. Bladder overactivity is another potential risk, with particularly stress incontinence surgery, specifically mid-urethral slings, so de novo or persistent bladder overactivity, including urgency, frequency, and urgent incontinence, may not improve post-surgery. So if someone has mixed incontinence, you would generally treat the urgent incontinence first. If that improves significantly, they have residual stress incontinence, then you will do urine dynamics, confirm that, and if lifestyle interventions fail and they opt for a surgical intervention, then you need to tell them that the pre-existing urgency may worsen, or if they didn't have that, then post surgery, they may develop de novo urgency. You also should discuss risk of synthetic slings, and this in particular mesh erosion into vagina, bladder, as well as infection and graft rejection. Advantages and disadvantages of stress incontinence surgery. So autologous facial rectus sling. So the advantages is, well, the literature quotes high cure rates, anywhere between 70 of 90%. It is effective in severe cases of particularly urethral intrinsic sphincter deficiency. These are autologous facial grafts, so there's no risk of rejection. The disadvantage is it's actually quite a morbid procedure. There has to be a laparotomy, therefore, significantly longer recovery, in the technical difficulty in retrieving those because they come from the rectus sheet. So this is really rarely performed. Retropubic mid-urethral synthetic slings, so the TVT. The advantages is that it's minimally invasive. There's short hospital stay, and it actually has the highest cure rate. So they're anywhere between 80 to 90%. The disadvantages is there's a small risk of minor bladder injury and bowel injury, mesh erosion, and it's like most of the other surgical interventions, less effective in severe cases, what we call frozen urethra, so intrinsic sphincter deficiency. The transobturator mid-urethral sling, the Monarch, again, similar to the TVT, and the advantages are minimally invasive, low obstruction rates. The obstruction rates are slightly lower than the TVT, and that is all equally operator dependent. The disadvantage is that it still lacks long-term data. Again, low effectiveness in severe cases. The bioinjectables, advantages are least invasive, repeatable. The disadvantage includes a low cure rate, so they're up to 78%. They generally sit at the 50% mark, and they need to be repeated. Female artificial urinary sphincter, effective in severe cases, so in ISD cases. It's complex surgery, and another disadvantage is the risk of device failure. It requires patient's dexterity. Adjustable continence therapy device, it's minimally invasive, it's adjustable. The disadvantages include limited long-term data, risks of infection, pain, and device failure. And this concludes our presentations, and thank you. I'm open to questions now, Leonie.
Hi, thank you very much, Omar. I just want to let everyone know, in the audience know, this is Omar's 6th presentation that he has done for us, and he's just done them off his bat. And it takes, as you can see, they're very comprehensive, and it takes a long time to research them. So just to thank him very much for all his hard work, and his presentations are very popular, and they get lots of views on the YouTube page too. So thank you very much, Omar. And we've got a couple of questions, but I thought I would ask first, if you were a 65-year-old woman with an overactive bladder and you didn't have much money, and you knew everything that you knew, what would you do first?
Yeah, so certainly the aside from your obviously, once you establish that diagnosis with confidence, I certainly approach with depending on her cognitive.
You're the person, you're the patient.
Oh, I'm the patient, sorry.
You're a 65-year-old woman with an overactive bladder, and you know everything that you know, and you don't have much money.
Yeah. So I'd see my GP, and I'll look at the GP guiding me through lifestyle adjustment, lifestyle changes, initial recommendations for behavioral therapy and bladder retraining, pelvic floor exercise. That's what I would do. And the information I provided is really what the physiotherapists do. They just maintain consistency. So I think that's an excellent approach, and I would attempt that for a period of a minimum of 6 to 12 weeks, as we suggested. That's the first thing I would do. Then I'll follow up on that to see if there's improvement. If there isn't improvement, I think equally I'd still push through with that first line interventions, and I would seek a referral to a community women's health physiotherapist. And we have an excellent department at the Canberra Hospital. I just think they're not well marketed, so I don't think the GP community knows how to establish contact with them. So that's the first thing I can happily provide. So I can, the referral are generally done on DHR, so I don't know in the GP.
I think we do smart forms.
Perfect. So all you need to do is really and I'm not the best with DHR, but my registrars teach me the simplest tricks, is to print pull up the patient, and there's at the bottom left corner, there's a action box or a follow-up box. And if you just put in physiotherapy, it comes up the referral, and so you can put that in and refer them through DHR. So I'd refer for physiotherapy, and then I would do that, and then I'd reassess in 3 months' time, and then I would look at adding a medication. Add an anticholinergic medication.
And so if you were adding a medication and now you've found some money, you've won lotto, lucky in the 3 months, which medication would you choose?
So
if cost wasn't an issue.
Well, if the cost is an issue, you haven't won a lotto. This is a majority of them. I would start with Ditropan. The dose needs to be small, so I would start with 2.5 milligrams at night time. And I would be very mindful of cognitive function. And if I had a little bit of money, or if I can afford it, I think if you probably want to factor in a slow release compound and consistency in taking your medication, I would go for a patch, the
Oxytrol.
Oxytrol patch. Problem with those patches is the skin reactions. And they generally will need to change them. So that would be and then after that, really tomatoes, whatever you pick. I think the cost is really similar for Vesicare and Abelex. They're both equally slow release, taken once a day. And if you have concerns about contraindications, then, or if they haven't been effective, I would probably refer for urodynamics before I change the category of the medication. And then the GP can refer to urodynamics as long as you have the appropriate indication, which we discussed, obviously.
Okay, so we've got some more questions, but can I just ask the audience, rather than raising your hand or typing into the chat box, can you type into the Q&A box and I'll read out the questions. So I'm going to go on to some audience questions now, Omar. So the first question is, it must be uncommon, but how would we assess for a fistula in a woman who leaks a small amount of urine continuously?
Well, that's a great question. Even in our world as specialists, and particularly those who have a special interest in urogyne, who deal with it, it's very challenging, particularly on a primary care level. So I think how I look at it is risk factors for fistula formation is the first thing. So, patients who have a poor obstetric history, think of that. Those who have got chronic bowel, significant inflammatory bowel conditions, those who have recently had a pelvic organ prolapse surgery. And then, as I mentioned, you look at symptoms. So acuity in symptoms is a red flag. It shouldn't happen. And then leakage at all times. So if you clinically want to assess it at a primary care level, it's difficult. But what we generally do is we'll put a catheter in, infuse the bladder with saline that's infused with methylene blue, and then you have to put a pack in the vagina, and then you have to wait for 10 minutes with a full bladder. Clamp the catheter and wait, and then you can empty the bladder, retrieve the gauze, and if you see blue dye, then you've got a fistula. And then you have to do studies, obviously, to determine the level of the fistula. Where is that? Is it, vagina, ureter, vagina, bladder, vagina, or urethra, vagina?
Yep. And there's another question, and I wasn't aware of this, but the question was that can GPs order urodynamic studies through radiology companies? I wasn't, and would they attract a rebate? So,
Okay, they can, did you say, sorry?
I wasn't aware that we could, but there's a question saying that they thought that we could order urodynamic studies through radiology companies. I wasn't aware of that as a possibility.
Yeah, I don't know. I'm unaware of, I don't know. Yeah, I can't really comment on that. I know, I mean, we do, there's a few of us who do them at Canberra Hospital. So, and there's no reason, I don't see a reason why I wouldn't accept a referral, deemed the indication is appropriate. And there's not really a huge waiting list for it. So a number of us do that. Yeah.
Before I ask some more questions, how often is it that people can get incontinence surgery on the public waiting, through a public hospital?
What's the waiting list?
Or how common is it, or what kind of wait would people?
So look, great question. There was a few years ago an inquiry into the use of mesh in treating vaginal prolapse surgery, and the recommendations came out of that, and that's all. There's a very good booklet that it's the Health and Safety Commission has put out, and I don't know how many of you are aware of it, but it's something we use quite consistently when we counsel patients about urinary, mainly stress incontinence surgery that involves the use of a polypropylene synthetic mesh. So the first thing to recognize is that this has been cleared by the commission, and it remains the gold standard. But quite frankly, so the first line treatment from a surgical perspective for urinary stress incontinence. The problem is all you need is a patient to come back and report pain, and then there's a spiral effect, and then there's a lot of litigation that comes with it. So the type of incontinence surgery that's offered, it really depends on the surgeon's skill, their view of the whole scenario, and their preference. So I generally do a lot of laparoscopic birch pulp suspensions. So these they're more invasive, but I do them laparoscopically. I'm well experienced in those, and I used to do tens and tens and tens of urethral slings, particularly TBTs, and that they have the best outcome, and they're really sustainable results. I tend to avoid doing them now, but these are the two most commonly done. So at the Canberra Hospital, nobody does them. I do the pulp suspensions, and I think Liz Gallagher does some TBTs. So that's really the two of us.
Yeah. So there's not much for public patients.
That's for public, that's for public patients. Yeah.
Okay, back to questions from the audience. Can you comment on Botox for urinary frequency in women with or overactive bladders with MS? Can we get this on the public system?
Yes, you can.
Yeah.
Of course, yeah, you can get bladder Botox for the public system. So again, I do them and Liz does them mainly. Yeah.
Okay. Now, oh yes, okay. This one is about using estrogen, topical estrogen, on elderly women, and does it work for overactive bladder? And also, is it generally safe for all women, or do we need to do a pelvic ultrasound or anything like that before we prescribe it?
Yeah, so I'm reading. So do we need to check for estrogen pathology lab?
Yeah, I'm just assuming that's just checking for the safety of using estrogen in terms of
So good question, very common question. So very good evidence.
Oh, I think they've elaborated as, I think it's this one. Do we need to check for estrogen level before prescribing estrogen pessary or topical creams, or we assume that levels could be low and can use estrogen blanketly in symptomatic women?
Yeah.
Would a pessary and topical cream bioavailability and efficacy, are they the same? And does it help with overactive bladder? So that's the question down below.
Yeah, thank you for an excellent question. So, and it's a very common question. So the first thing the patients will go, oh, is that going to increase my blood levels of estrogen? The answer is absolutely not. Very good evidence. Local vaginal estrogen treatments do not raise significantly estrogen blood levels. So hence doesn't increase risk of breast cancer or the other issues that relate to oral HRT. We do not need to check the levels because the levels won't be changed in the bloodstream. And can use estrogen blankly. And so pessaries and topical. So in my opinion, based on my experience, I feel pessaries are more effective because the distribution is more equal within the vaginal mucosal lining and the bladder base. Problem with the cream viability, it washes off very quickly, and you probably half a dozen times won't get it right up to the apex. So I generally prescribe pessaries for particularly when they've got urinary urgency and overactive bladder syndrome, and it can be quite effective, particularly when the urinary urgency is related to atrophic vaginal changes due to lack of estrogen.
What about in women who've had endometrial cancer or
radiotherapy and chemotherapy? So
that it's safe for those women and women who've had endometrial cancer as well?
Yeah. So women who've had endometrial cancer would have had a hysterectomy.
Yep.
And the evidence we have for HRT use in women who've had hysterectomy and BSO is that estrogen only is actually safer than estrogen and progesterone.
Right. Yep.
Yes, so it can be used. Using it in those who have had breast cancer, the recommendation is used with caution, so meaning refer to a gynecologist, have a discussion. It depends on the breast surgeon. So, the breast cancer, estrogen and progesterone receptor sensitivity. So the oncologist generally would make a recommendation.
Yep. And what about women who've used prolonged vaginal estrogen? They have a uterus? Are they at any risk of hyperplasia?
No, they don't.
No. So you don't need to do any pelvic ultrasounds to check for endometrial thickness.
Correct. Yeah, you do not.
We've got a follow-up question. It says, if the woman prefers topical cream and avoiding pessary, where on the body should it be applied? Oh, I think that I'll answer that one. So the topical cream is per vaginal. So it's Vagifem, the topical cream. That's correct, isn't it? Or you can have a Vestin topical cream.
So Vagifem are the suppositories.
Oh, they're the, yeah.
Vestin, you can have it in the form of cream or suppositories or tablets.
Yeah. Okay. And you may have mentioned this earlier on in your presentation, but you said, is your incontinence night versus day? Did you mention what that meant? Yeah,
so day and night. So day is the, urgency and increase in frequency and periodic episodes of incontinence. And the nighttime is really nocturia.
Yeah. And so if they have nocturia, it's more likely to be overactive bladder. Whereas if it's daytimes, you'd be thinking overactive bladder or stress incontinence.
Well, no, nocturia could be part of an overactive bladder syndrome, but nocturia should be differentiated from polyuria that can flow over to nighttime, and that obviously is managed differently as excess fluid intake.
Okay, thank you. I think we'll wind it up there unless there's any more questions from the audience. We've had a pretty good kind of session of question and answers. Lots of people have been typing in. And just wanted to say thank you again so much for doing this and also battling through a sore throat, I think. Yep. And just to let everyone know that we will be posting it up on the Capital Health Network YouTube page in a couple of weeks. Please fill in your evaluation surveys. We'll be sending out a certificate of attendance and to record 1.5 hours of educational activities to your CPD home. Thank you again very much, Dr. Adham. Thank you.
Thanks very much.
Okay, thanks. Good night. Bye.
Yeah.